From New York Medical College Heart Disease Research Foundation here in the US. Dr. Amura received oncological residency training at Cancer Institute of Columbia. He is well known to this meeting, one of the organising committee members. He has a great insight into interpretation of the ECG. I remember last year's presentation as well. And he will be presenting, do we have your title, presentation?
Yeah.
So, which one is it out of these here? The presentation, stage 2. Is it loaded on here? Which one is it?
It's called Philadelphia
Which one?
2015.
Okay.
Philadelphia.
Okay. This one?
Philadelphia 2015.
Yeah, that's the one.
Yeah.
That one?
Probably, yeah.
Okay. So you're going to give the presentation?
Oh, disappeared.
Ah.
Oh, what happened?
It's a very sensitive pad. All you have to do is just minimize it here. Okay? And it's just the arrow there.
Okay. Good morning. I'm going to present a new method of detecting various cancers and drug taken within 12 hours from rapidly changing QRS complex or rising part of T wave of recorded ECGs. Which one? Can you help me?
Why don't you present and I'll
Yeah.
move the slides.
Okay.
Just over here.
Yeah.
Okay, there we go. Good one. Is that one okay? Is
Okay.
that what you had?
No, there's a few slides missing.
That one?
Yes.
Okay.
Okay. The laser beam is projected. Information on the molecular structure and amount will be transmitted bidirectionally. And to the direction where laser beam is going, as well as the information goes to the source of the laser beam. Using this information, we have been using for the diagnosis, non-invasive diagnosis from distance. Oh, that one.
Yeah.
And this is the example. So if there is the same molecule we are testing in that particular. Okay. If this person hold some molecule related to the cancer, and if this location have a cancer parameter, we can immediately detect. And so using this, we are scanning whole body, but the problem is laser beam does not go too deep, and therefore we have to do the front, back, and side, and which is not convenient. So we try to see if there is any other simple way to get the information in shortest time. And as a result, we thought by having a electrical impulse with a very fast high frequency component with a large DVDT that should produce all the necessary information. And So we were intending to make such a device, but I suddenly realized that electrocardiogram have a QRS complex, and part of that has a high DVDT. And we wanted to see if that can pick up all this information on cancer and any other information in the rest of the body, since electrocardiogram reach most of the part of the body. And using cancer screening kit, which contain most common 75 microscope slide of the cancer. And we found slide. And so we are testing from this multiple myeloma slide, and when they have a patient, electrocardiogram was taken from multiple myeloma patient, it will produce strong electromagnetic field resonance. And this technique is used by using the US patented technique of detecting electromagnetic resonance phenomena between two identical molecules. And we found a number of the new things. When you have a X chromosome and the Y chromosome, using this, we tested if they produce any resonance with any part of the electrocardiogram. We found this is the only one produced every part of the electrocardiogram. And also, by using that particular area of the highest DVDT, if the voltage is more than 1 millivolt and sometimes more than 1.2 millivolt, we can detect not only can exist in cancers, but also cancer-related parameters and molecules. And therefore, this can be used for not only detecting, but evaluating therapeutic effect of any treatment for cancer. And these are the example of the different electrocardiogram. For example, this is adenocarcinoma of stomach. We can detect with the microscope slide. And also, when they have some medicine, we can also detect in the almost same location. And these are, this is a case of the multiple myeloma patient. And when you have a resonance, we check the maximum resonance is -12, and -1 or -2, that has a minimum resonance. And when you get the maximum resonance, you get not only molecular diagnosis, but also information on the molecular structures and related cancer-related parameters we can detect accurately. And these are some of the examples. For example, Oncogen, 307.5 nanogram, and 8-hydroxydeoxyguanosine, 2.5 nanogram. But when this, if you check like -1 resonance area, you can make a diagnosis, but you cannot get full information of the biochemical associated phenomena. For example, this electrocardiogram is not enough to have a large DVDT. They can only produce -3 resonance, and therefore we can make a diagnosis from here, but we cannot get the accurate information on the cancer-related parameters. But here is a big change, and here we can get -12. Here we can get correct information. And before and after treatment, for example, you can see these are showing the same patient before treatment, and V4 and V5. And V4, this part is not enough to produce exact molecular information, but we can make a diagnosis. But this part with -12 maximum resonance, so we can not only make a diagnosis, but we can quantitatively measure the related parameter as long as you have an identical molecule to produce resonance. And this is a before and after. For example, this was after 400 international units of vitamin D3 is given. You will see the big changes. Oh, slide is missing, but anyway. This is a case of adenocarcinoma of colon. And this one, we have a whole full resonance, -12, so we can get the correct information of diagnosis and all the detail of the molecular related factors. But this part of the electrocardiogram, DBDT is not so great, so we can get the maximum -2. So the information is only partial. Instead of 252.25 nanogram, you only get 30 nanogram. And this is the adenocarcinoma of the colon. Again, we are checking the effect of the vitamin D3, which is quite efficient, and cancer marker reduced less than 1,000th. This is the adenocarcinoma of the colon after giving vitamin D3 400 international unit. Cancer marker of a few hundred nanogram become 0.002 nanogram. This is one of the most efficient result of treatment using any anti-cancer treatment. And we had in this case, with the electrocardiogram, which is shown before we know anything about the patient. From electrocardiogram, we found a colon cancer and ovarian cancer. And the standard laboratory test-based diagnosis was colon cancer and uterus cancer. And study showed the finding from electrocardiogram was correct. And also here in the ovarian cancer, you see this abnormal projection of red area. And this also produced strong resonance with the microscope slide of the ovarian cancer, not uterus cancer. And again, this is a control. After treatment with 400 international unit vitamin D3, the cancer reduced to 0.0005 nanogram, and 8-hydroxydeoxyguanosine reduced from 2.5 to 0.25 nanogram, which is a completely normal range. And this patient was suspected of having pancreatic cancer, but I was given the electrocardiogram. Electrocardiogram finding was ovarian cancer. And it was later on, it was confirmed ovarian cancer was correct. And ovarian cancer, you also have this projection in here, reddish projection. Although this picture doesn't show well, but and also she has a abnormal finding in the bone marrow representation area. And the bone marrow representation area is represented here. And often bone marrow-related malignancy, they show abnormality. And also some other cancer, when you put electromagnetic field laser, they produce a significant reduction in cancer-related parameters. And we check the substance and unknown substance given by my associate, and we were able to detect it was vitamin D3 400 international unit. And some of them, it was a dejection in the patient with some problem with the heart. I think based on this, I can conclude that contrary to the general idea that it's impossible to detect cancer from electrocardiogram, but we are finding from electrocardiogram is more accurate than any other method we compared. And also, we can also detect different infections like human papillomavirus 16. We found all the cancer we have shown had a human papillomavirus 16 in the same area of the QRS complex. And also we found in the rising part of the T wave, which was a big surprise for us. And another things we don't quite understand is when we test with the chromosome for sexual chromosome X and Y, and we can detect the electrocardiogram belong male or female. And also when the man with the homosexual, they show additional resonance with part of the X chromosome. And we found most of the medicine patients take within the previous 12 hours, we can detect if we have an identical sample by detecting presence or absence and the degree of resonance. In conclusion, the method can be used as a very useful method of new method of detecting cancers and related cancer parameters, and therefore we can use and evaluate effect of any treatment before and after. And also we can, if you have electrocardiogram of the old electrocardiogram, sometimes we can tell when cancer start appearing. And also we found even they have a multiple cancer, they all show up around the same area. Thank you very much. No, just one. Yeah. But when the voltage is small, you cannot pick up because you cannot get the resonance because dVdt have to be larger. That only limit. So we only pick up the highest voltage.
100 million. Some people positive. More than 10 have been clinical work. There is predicting the to reflect there is any change to do the not CT image could show the blood vessels whether there is cycle can show whether there or the so if there is a calcium dangerous, it will be called and then maybe called will be very vascular pathology, and then we test the in the blood and age, gender, them may be more important than any other, even compared the virus. And then we focus on the homocysteine, since it is very special small molecules in the blood streams. So when we compare the different conditions of stenosis, there is a very good correlation between homocysteine and the stenosis. That means the pathology changes is maybe caused by the homocysteine. And then we try to compare the well-known risk biomarkers, homocysteine with stenosis relationships, and even the contribute much more than the lipids. Excuse me. And if not calcified and calcified, there is also between the age, that's no problem, since everyone knows that the more aged people will be causing some dangers, and homocysteine both contribute much more than any others. So that means if there is patients, they have hypertension or hyperlipemia, and if they also have homocysteine, they will be causing more easier to have the calcified plaque clot, so that these kind of patients will be more easier to suffer some unstable angina, and then maybe more easier to have AMI. This is when we compare calcified plaque clots, the age may also have some contributions for that, and total cholesterol and LDS cholesterol, so it seems only a little bit. This compares all of them, and we found the homocysteines correlated with the calcifications for that, and the quadrilateral analysis for the homocysteine, there is reversed correlations. And this is another figure to just show you the calcified plaque clot. If much higher homocysteine will be more easier, about 6% to be happened that. So if we using homocysteine as a risking factors, the patients already have some cardiovascular disease, and the homocysteine, the cutoff value, according to this group of disease patients, which is the cutoff value maybe around 15. but in the clinical use in China moment for the general people is only is about 20 micromilligrams, but we could not using that for separated patients with calcified. So the 15 might be the very good cutoff values for this group of patients. So at the moment, we this part of work just show you there is a relationship, and also homocysteine in the blood is much more much good predict the conditions of pathology, conditions of cardiovascular disease. And since homocysteine is very similar, it's found about 80 years ago, and it's maybe related with the methionine and the homocysteine. There is some metabolite for that. And the further study show that's also causing the stress, the oxygen stress is related with the cells metabolizing. So it will be causing the nitric oxide decrease, active the stress genes, and also causing the inflammation. So that's more easier, more important rescuing factor. The second part of work is for using the ultrasonic, try to find there is some disease, some pathological changes. Is MIT, so and also with there is some plaques. This is just to show you, since if there is some other areas have some problems for the vessel, normally here there is. So the rescuing factor with there is a correlation with the change, pathology changes here. And often find that the well-known biomarkers for lipids also have some relationship, but between among of these lipids, maybe the ratio of total cholesterol and HDL-C, and also another is LDL-C and HDL-C ratio is more important than just using the individual ones. So we try to find the relationship between these lipids. And just to show this one, just show you not only related with IMT and also related with the plaquenil. And this is a contribution of different lipids to the pathological changes, and then using RC curve to show each contributions of lipids, and then we found combine them together. This will be more get more information than the individual ones. And even we combine LDL and HDL by using as a largest regression model, it will be more useful. In this work, just show you the just combine the lipids together is more useful for the MIT, the thickness of the vessel, and also the both using a mathematical model will be more useful for the plaquenil. And the last one is try to find if there is some new biomarkers for, such as microRNA is have some relationship with cardiovascular disease, and we also using the patients in a hospital, and first using 15 for screening, and then using 100 patients for validation. That's the diagnostic criteria, and we sequence the microRNA in the blood, in the serum actually, by Huada in China, there is a big company try to doing the research service. They give us this screening data. This is the patients. At first, each group there is 15 patients for screening. This is the patient conditions, and this shows the quality of their sequence. That's the company give us this data. Just shows that data is perfect. There is no problems. And then we find in the blood, in the serums, that's really have high concentration of micro RNAs. It's about 22 base here. And then using bioinformatics, we found that there is some related microRNAs. The most important, finally, they show there is 3 new that's not reported before. It's more related with this disease such as atherosclerosis or unstable angina. And then we use 100 patients to try to validate this data. This is the supposed structure of the primary microRNA of these 3 new microRNAs. And then we compare the control and the atherosclerosis. Almost there is no difference. But if you come to the unstable angina, you're sure that both 2 of these new microRNAs will be increased sharply, but the number 1 almost stable. When we see the AMI, that's more dangerous conditions of patients, all of 3 of them have sharply increased. There is statistic difference. And we compare the unstable and the stable, such as since the patients, if they have stable angina, there is almost no problem. Maybe just tired, and it will be recovered soon of the relax. So compare both of them. Although there is no statistic difference, but there is a comparatively higher microRNA of these 3 new microRNAs in unstable than the stable ones. So from this result, that's just the primary data for this work. We will be further validate for that. If that's really useful, we may be using these 3 as a pattern, such as in the only 2 of them increase, that may be the unstable angina. If 3 will be soon become the AMI, so that we can earlier protect the cardiovascular death for disease. And finally, I should thank all my groups. The main work have been done. This is for Dr. Sun Yang Cai, this one, this lady, and also Sun Qiyu for another PhD doctor. Okay, thank you.
Any questions from the audience? Well, that was interesting. We look forward to more follow-up with these novel biomarkers.
Yeah.
So tell us about more patients next year.
If there is a relationship.
If there's really good thing. Thank you very much. I think there's a little certificate for you.
Thank you.
Thank you for coming and presenting very interesting data. Okay, is Dr. Hirose. So let me introduce Dr. Hirose to you. He's going to talk about a little miniaturized transesophageal echo probe that is used in the intensive care unit at our university hospital. I work with Dr. Hirose, and very, very talented cardiac surgeon who
and the evolving technology. This is we call it so-called HTE, abbreviation as stands for the hemodynamics transesophageal echocardiogram. So this is a very small miniaturized, like a 5 millimeter of the diameter, almost the same size of the NG tube. You can put into the patient mouth down to the esophagus to give us an image of the heart. So concept is regular TE has a large size, and we have to call in the cardiology or other folks to get the equipment ready to the ICU and personnel to the ICU. However, in this technology, we have in the intensive care unit all the time, so the intensivists can put in. Actually, our mid-level providers and even residents can put in this echocardiography to see the heart conditions. Usually, we do this method in the patient and intubated setting. It's a little bit hesitation to do the awake patient without intubation because of the issue of the back and forth and the control of the device. Give us a good picture of the heart, and we'd like to show you share with you a couple of the cases, and we treated with this device. So this is the console on the left, and then this going to the patient esophagus to give us the pictures. So a couple cases, 80 years old, obese, and vasculopathic. Patient had MI, intubated in shock, patient on the drips. We did a transesophageal echo, transthoracic echo, but it was very poor window because of obesities, a BMI like a 40. Unfortunately, patient did not have a Swan-Ganz catheter to monitor cardiac output because of the presence of the temporary pacers and also the carotid surgery and scar there, and then we couldn't identify the IJ. So this patient in shock is it the volume issue or cardiac issue? And then we put on this probe, and we couldn't figure out before happening, but apparently heart is moving. If you can dim the light, they can see the better. Heart is squeezing very well. So we decided not to do any catecholamine. We'd rather to go to give them more volume to get the heart fill. Thank you. And in addition to that, this probe will stay in patient esophagus maximum 3 days. If you can get a new probe, you can put on additional 3 days. You can do forever. You can leave it in safely. For example, regular TE, we can't leave it in more than a couple hours because of the heat productions. This doesn't produce the heat. So it's very safe to just continue to monitor their heart without eating the patient. You're giving them a volume, shortly after, blood pressure improved, heart was filled in very well. So case 2, this is a patient who had day 14, who had a left ventricular device, had a fever and pressure dropping, and worry about our patient getting sepsis or right ventricular failure, what's going on, we have no idea. And then again, they did a transthoracic echocardiography. Because the device sits on the left chest, they can't see the heart very well by regular echo. So we put them in, and then we saw the relatively large pericardial effusion over here, which was compressing the right ventricle downward. So however, the ventricular function itself is normal. So the patient went to the OR. So this device can save the time and the diagnosis, and also save the people coming into the hospital to do the procedure. Again, this HTE will be done by the even resident or fellows or the mid-level provider NP and PAs. Another case is day 7 of LVAD, similar story, hypotension, the issue. And then we had a patient had hypotension. So if you look at this picture on the left, this is septum. Septum is burning towards the right. So the essentially is right ventricle is squeezing very well, but the LVAD will need will need more flow to go into the VAD. So we increase the speed, and blood pressure got better, and also septum. If you look at this septum, is midline. So this is the thing we can using this device, we can adjust a patient VAD speed or any VAD adjustment. It's very easy. Another case is a patient had a chest tube drainage. The patient had a biventricular dysfunction, pulmonary hypertension, and bad heart, and had a cabbage AVR and a massive dose of the pressurizine. Initially had a high chest tube output, coming down to the last 2 hours, MAP dropping, PA pressure is high, CBP is high, but it's, oops, I don't know why this happened. Sorry. If you look at this, if you call a surgeon will argue this number is the same as pre-op, right? This number is pre-op, same as pre-op. So what this, we have to find out, this is a ventricular failure, neither device Dr. Samuel introduced, or the patient had a tamponade, or because of the chest tube not draining. So apparently, if you look at this, you can see the big clot sitting onto the left ventricle. This is the left ventricle start here, and this is compressing. So tamponade diagnosis was made quickly, and then the patient went back to the OR. So we did a correct diagnosis without any spending extra time to do the other maneuvers. Other cases, mitral valve stenosis. This device is not good at look at the valve function, but this device is not designed pressure to measure pressure gradient. This device is not measuring the what you call the regurgitation. There is a car capability, car Doppler capability, however, it's not perfect. So essentially, you're looking for the functions, empirical space disease, and also the septum to adjust the mechanical devices. So what this is, mitral valve stenosis, and CBP is a high side, and index is okay. And then what's going on, and this is a patient, the right side is not moving much. So this is the mitral valve open, closed very nicely, like a mechanical valve. Because mechanical valve, the transthoracic echocardiography was not working well. And then we started the dobutamine, right side started moving well a little bit. And then so another one is we have another device, which is ECMO. Will support left and right ventricle same time. And the patient had a shock and putting on to the ECMO in, but the ECMO was not flowing very well. So we put in, had to find out. And the right ventricle is very decompressed very well, but the clot, this is a clot, big clot in the right atrium. So we bolus the heparin, and then we gave them more PTT go up, and then after that, the clot was disappeared, and then the ECMO flow well. Another one, for example, patient had start on ECMO, we have to wean the ECMO, like a Dr. Samuel present, or right ventricle dysfunction, put the right ventricle device in, and we have to wean. We use this device because we can continue to monitor. We have a protocol established. We come down the flow little by little. Takes like 4 hours of weaning protocol. And then we have to see this one. This one is a patient had not doing well. Patient had completely stand still, and heart was not moving. And then patient had a couple of days on the ECMO support, and then like 2 weeks of ECMO support, we start doing some of the trial. However, the patient going down to the ECMO floor start distended, and heart was not happy, not much moving on the right side. So we have to do it again, and the following week, and it seems like to me that because we support the heart very well, decompressed and got better. And you can see it on the left side, and the 4 liters coming down 3.5. Heart will start moving, and the 3 liter, and then even happy. This is right, and on the left side, this is the left ventricle. So the 1.5, and then their vigorous motion, we are able to get rid of the heart. And by the way, and this is a patient who had almost cardiac arrest. Nobody believed this is happening because the initial picture we show you, the heart was totally distended, doing nothing. Extubating following day and home 2 weeks. This patient is present my clinic like a couple weeks. Of course, we have a patient we couldn't wean. In that case, we present here. We have heart is not happy. Heart is not happy heart at all. But we try to come down. Again, heart is not happy, right? So in this patient had right side is pretty better compared to the left. Issue is the left side issue. And we adding on some inotropes. Left side is persistently bad function. And then if you keep going 1 liter, right side even failing. So this patient had a total artificial heart. He has been supported artificial heart almost 1 year. He got the transplanted a few days ago. He's doing well. So we have some of the protocol written and how it works. We find out which side of the ventricle need to be supported for the longer time after the ECMO. We have a couple of slides we had to go through. The patient had a ventricle function. We can easily detect by this technology. And then we are easily to detect the tamponade. Of course, patient had dissection. It came in with a chest tube drainage, and then the patient had low cardiac index. We worry about the tamponade. Some patient obviously not having a tamponade, but just ventricular function, this ventricular dysfunction because of the poor protection from the dissection. So this is all similar cases, and then so the Swan-Ganz catheter itself may not be helping to make a diagnosis, and then there sometimes need more adjustment based on the invasive. This is, I don't know if it's called invasive or non-invasive, relatively less invasive procedure. So we have it's written there, but I think I go to the conclusions, right? Sorry. So conclusion is HTE can evaluate the heart function very easy, and then especially ventricular function, pericardial disease, and patient had mechanical ventilators, mechanical circulatory assist. We can adjust the speed, or we can adjust wean a VAD or ECMOs at the bedside. It's very easy tool. This is one of the things we have been using our unit over probably 3 years, and then we change our patient management very dramatically. Thank you for your attention.
I hope you enjoyed that as much as I did. I think this is a tremendous tool for the ICU to rapidly diagnose and treat conditions that require immediate attention, whether it's pericardial tamponade or something else. And it's so quick and easy and simple. A couple of questions for you. Just to remind
anatomic bypass in case of adult aortic coarctation. The adult aortic coarctation is a challenge situation for managing, and in the last decades, we have developed many techniques, many minimal invasive techniques for that. But some patients sometimes decide not to operate. And in this situation, these patients are subjected to have complications related to severe hypertension, heart failure, and vascular complications like the claudication pain over the both legs. Based on that, the indication of surgery is the aortic coarctation itself, the aortic recoarctation, the concomitant procedures like the anastomotic pseudoaneurysm descending aorta and associated to aortic valve replacement and so on. Some surgical considerations we can detect before the surgery in terms of the location of a narrow segment, the anatomy of narrow segments, the correct position of the segments, the quality and the quantity of the collateral circulation, and if you need procedures. As to the surgical techniques, we have three big modalities. That is the conventional open procedure, the percutaneous endovascular procedure, and the focus of my presentation, that is the open extra anatomic bypass. We know that the conventional open procedure can be performed using two access, the midline sternotomy or the left thoracotomy. Specifically, in relation to the conventional open procedure, we have to use, in most cases, the cardiopulmonary bypass associated with deep hypothermia, more or less 15 or 16 degrees. And the techniques used for this kind of procedure are the resection of direct anastomosis, the PET arthroplasty, or the interposition tube grafts, generally using PTFE or Dacron grafts. But there are many risks to be considering to call attention for the surgery. And these risks are related to bleeding, the massive hemorrhage, the nerve injury, the paraplegia, that is the biggest risk and the most terrible risk, and the cerebral dysfunction. The percutaneous endovascular procedures carry some aspects like the balloon dilatation associated to stenting, and there are some limitations or risks related to calcification and the diffuse tubular hypoplasia. In these cases, when the aorta is very calcified or the aorta has a design of a diffuse tubular hypoplasia, these two situations are not good for using the percutaneous endovascular procedure, and in these situations, the open extra anatomic bypass is feasible. As I said, the open extra anatomic bypass can perform using three kinds of approaches: the midline sternotomy, the left thoracotomy, or associate, in case of complex case, the median sternotomy plus laparoscopy. Particular for the open extra anatomic bypass, we have some advantages like the reduced dissection of coarctation. The surgeon doesn't need to manage this critical zone of the vascular system. We need to have caution to reach collateral net because we have accidentally hurt or injured this net and provoke massive hemorrhage. We don't need, in most cases, to use the complete clamping. You have to clamping partially, and this allows to keep the flow downstream. And we can employ this technique with no cardiopulmonary bypass, or at least with a shorter cardiopulmonary bypass time. And we cannot explore or manage in excess the left hemithorax, as well as we can use a slight retraction of the left lung, thus not provoking postoperative lung complications. But there are some injuries related to esophagus lesion, the IVC, the inferior vena cava complications, or in some cases, the right inferior pulmonary vein injuries. We can use, as I said, the median sternotomy plus laparotomy in some specific and particular case. And when you decide to adopt this technique, this strategy, you have to bear in mind that the good site for anastomosis, the good size for anastomosis into abdominal cavity, is exactly the infrarenal abdominal aorta through abdominal cavity, or you can use the retroperitoneal approach in order to avoid excess of gut manipulation. When you use the median sternotomy plus laparotomy through the peritoneal cavity, you can use a shorter prosthesis. Sometimes it's necessary to graft envelope, exactly to avoid the gut manipulation. And there's a risk, depending on the exactly length of the graft, there's a risk of kinking or deformation of this graft. The surgeon needs to be that point in mind at the time of operation. And the do this same operation by using the retroperitoneal approach. In this case, is most adequate to use a longer prosthesis, and you cannot, there is no risk of manipulation of gut in this case, but sometimes it's necessary to make some tucks to adjust the length of this graft. Here we have all the designs for this surgery when the approach is intrathoracic. We have from ascending aorta to the descending aorta, anterior and anterior. We can do as well using the left subclavian to descending aorta. We can put on the right side of ascending aorta like that and like that, depending on the length. And you can make a shorter prosthesis. The best situation, the best recommendation is this design with a long curve from the right side of the aorta to the anterior portion of the descending aorta. This design provides better situation in terms of reduce the risk of deformation, tortuosity, or kinking. But when you use, or you decided to use the left thoracotomy, the best design is that one, is this one. You can put on the anterior portion of the aorta, ascending aorta, to the anterior and proximal portion of the descending aorta. There are some cases in which we have to do concomitant procedures as the aortic valve replacement and CABG. And even in this case, we have to make the extra-anatomical bypass using the right aspect of the ascending aorta, routing the blood to the descending aorta, passing or beneath or over the IVC. There are two options. Route the blood through this graft, passing the graft beneath the IVC or over the IVC. These two situations are very useful and reproducible. This is a CT view to demonstrate this situation, the same situation. It's a postoperative result. We can use another strategy in case of concomitant procedures. You can replace the proximal ascending aorta in case of acute dissection, for example, or proximal aneurysm. And in case of aortic coarctation associated, you can bypass this graft from the aortic arch to the proximal portion of the descending aorta. How to prevent graft kinking? This is a cornerstone aspect of this technique. You cannot leave any possibility of graft kicking. You can use the right side of the ascending aorta, routing the blood over the IVC or beneath the IVC, as I said, to the anterior portion of the descending aorta. Or if you can decide to use the abdominal approach, you can put the graft proximally on the right side or anterior portion of ascending aorta to the abdominal, infrarenal abdominal aorta. Take a look that this graft is a little longer, exactly to avoid kinking or deformation. That's a real case demonstrating the mediastinum enlargement in which the patient presented with the big tortuosity at the level of isthmus and underwent this technique from the right side of the ascending aorta to the anterior portion of descending aorta with a good result. That's another case demonstrating a very severe aortic coarctation at the level of isthmus and the postoperative result with a good flow through this graft coming from the right side of ascending aorta to the lateral or anterior portion of descending aorta. This is to highlight the issue of the retroperitoneal cavity. You can open the chest, and at the same time you can open proximally the abdominal cavity. Use a very long procedures from the ascending aorta to the infrarenal abdominal cavity, and the idea of using these longer procedures is exactly to avoid deformation, kinking, or any kind of tortuosity. There is a very important impact of this technique, the extraanatomic bypass, on collateral circulation in terms of reducing the quality and the quantity of this collateral circulation. Take a look on the left side. This is the aspect prior to surgery. And on the right side, you have the lung tube communicating ascending aorta to abdominal aorta, and the reduced aspect in terms of collateral circulation if you compare with the prior to surgery aspect. This is another case demonstrating the left side is a massive amount of collateral circulation. This is a patient with many symptoms, with limitation to walk around, to claudicate, and after more or less 6 months after the operation, the result is very, very, very good, with this lung tube communicating the ascending aorta to the infrarenal abdominal cavity. This is a very particular case coming from my personal experience. This is a 38 years old man who was referred to my institution presenting with many symptoms, with limitation to work, to walk around, to everything. And this is a CT scan demonstrating a big amount of collateral circulation coming from the upper portion of the body to the inferior portion. We have another aspects. There are many communications jeopardizing the flow and the temperature in the limbs. This patient had even communication from the internal thoracic arteries bilaterally to the inferior portion of the body. And this is the last image prior to surgery. And so many communications and very, very difficult to understand how big these communications were. These two images represent this situation. And in the post-operative period of time, we employed the extra anatomic bypass from right side of ascending aorta to the anterior portion of descending aorta. We open the chest by midline sternotomy, and we put a graft from the, you can see here one image of the graft proximally to the descending portion. There's another image too. There's a very interesting result demonstrating the big graft coming from the right side of descending aorta, ascending aorta, and coming to the descending aorta, providing a good flow and redriving the flow in a most adequate fashion. Another picture demonstrating the operative result of the operation. And I think the most striking view is if you compare the preoperative aspect of the collateral circulation, take a look to the postoperative aspect, demonstrating the big graft communicating the ascending aorta on the right aspect to the descending aorta, but the most striking view is the important reduction of the collateral circulation quantity. This patient in the postoperative time recovered from the claudication, the pain, the limitation to walk around, a better control of hypertension, and so on. That's another image. On the left side, you have the preoperative feature demonstrated a big amount of collateralization, and on the postoperative time, you can, 6 months after the surgery, you can see the big quality of the graft, but the most striking, again, aspect is the reduction of collateral circulation net. In summary, we can point out that using this open extra anatomic bypass, we can get away from the critical zone. That is a critical zone because it causes paraplegia, renal problems, vascular complications, and so on. This technique provides reduced inflammatory impact because you don't manage or tackle with in the very fragile vessels, okay? It's feasible to get regression of the collateral circulation over time. It's possible to alleviate the clinical manifestations, mainly the hypertension complications, vascular complications, limitations for work, for walk around, and so on. We can progressively discontinue the use of medicines. Usually these patients use so many kinds of medicines to keep the arterial pressure on control, and ultimately you can reduce the morbidity and mortality over time. Thank you so much.
That was great. Big league surgery, but very, very well done. And I'd love to know, have you followed out these patients over years, or it's too early to say?
Yes, sorry, I have followed this patient, and this patient has, at this time, is 2 years from the operation. He's very well, doing quite good, working normally, running, playing sports, no complications.
Any need for anticoagulation or antiplatelet therapy?
Yes, I have used antiplatelet, no anticoagulation, just antiplatelet.
Oh, that's great. Any questions from the yes?
Music Production. is looking at the changing paradigm to an extent of cardiac surgery. If not all of surgery, we're attempting to see whether or not minimally invasive techniques to access our operative goals, I guess, are possible. Those who are in favor of minimally invasive techniques say that things such as the small incisions are quite helpful, and they provide a benefit to these patients because there's less surgical trauma, there's less pain to the patient. You know, cosmesis isn't that important, especially to us surgeons, but to the patient that is an important factor. And all of this actually cumulatively for the patient can help with the recovery post-operatively. So those who are not in favor of surgery say that, well, it's sort of common sense. If you're using a smaller incision, you may have poor exposure. You may not be able to adequately visualize your operative field, and it could tend to make the operation longer, potentially more dangerous for the patient. So in our study, we wanted to look at our experience in terms of performing minimally invasive surgeries, specifically aortic valve replacements, which you have two specific minimally invasive approaches. One is actually through a mini right-sided thoracotomy, usually between the 4th and 5th intercostal space, about a 4-centimeter incision, or a mini sternotomy, which maintains the normal midline incision, just uses about less than half of it. And we compared that to the conventional sternotomy used for cardiac surgery. We looked back at our database over a 2-year period, and we had from one surgeon a total of 189 aortic valve replacements. I'll show you the breakdown of each of the 3 types, but again, a mini thoracotomy, mini sternotomy, or a conventional sternotomy. We used chi-squared and logistic regression analysis to analyze our data. You can see here the patient demographics of our cardiac surgery candidates. They were mostly men. You can see that most had a history of smoking. There were diabetics and hypertensives, patients with hyperlipidemia, of course, low incidence of chronic renal failure. Some had a history of cerebrovascular disease and stroke and congestive heart failure. Looking more specifically at the aortic valve, the majority of these patients had aortic stenosis, 93% of them. In terms of their aortic insufficiency, you can see it was the gradation of trace, mild, moderate, and up to severe in this cohort. Looked at their aortic gradient, and also more importantly, the type of implant that we used in terms of valve replacement. Vast majority, 95% of these were bioprostheses as opposed to mechanical. That may be a reflection of the advanced age of our study cohort. So in terms of the breakdown of the 3 different types of aortic valve surgery, we had 33% of the patients undergoing a conventional sternotomy. The mini sternotomy comprised 23% of our patients, and the mini thoracotomy was 43%. Here are the results of what we found. Overall, the incidence of prolonged ventilator support, which was greater than 4 hours postoperatively, renal failure, AFib, having to go back to the operating room for a bleeding event, and stroke were lower in these patients who underwent specifically the mini thoracotomy group compared to mini sternotomy and conventional sternotomy. This was a trend, however. These were not statistically significant. You can see that in the graph here, everything that we just talked about numerically seems like they're lower. Again, these are non-significant values, but we did see a trend in terms of improved outcome with this mini thoracotomy approach. Same with the mortality overall. You can see there seemed to be a trend for both of the types of minimally invasive operations to better survival when compared to the conventional sternotomy. Our 3 significant data points that I think many in the audience could predict in terms of the minimally invasive approaches were decrease in the ICU time in terms of hours, and the mini thoracotomy was statistically significant even compared to the mini sternotomy or conventional sternotomy. Postoperative length of stay and the overall hospitalization, those are all very clearly in favor of the mini thoracotomy approach. In terms of addressing whether or not their smaller incisions would lead to longer operative times or difficult exposure, we did see there was no difference in terms of the operative times. We're looking at both cross-clamp and bypass time. And in fact, if you were to look more recent data, again, this data set only looked up to 2013 and was introduced when a new chief of surgery came and actually brought this technique to our hospital. Now, these times are actually much shorter now. You see cross-clamp and bypass time anywhere between the 40 to 60 minute range at this time. So that even with the improved techniques that this, and the fact that we've been doing it for so much longer now, I do think that in fact the mini thoracotomy, if you were to look at that, would be much improved in terms of these times. And again, the analysis of all of our complications, we did see that we had a shorter ICU time, shorter postoperative length of stay, and overall hospital length of stay in these mini thoracotomy patients. And we did see that that trend in survival was better for both minimally invasive techniques. So we concluded that the mini thoracotomy approach shows a decreased length of stay, decreased postoperative length of stay, and overall duration of hospitalization. The postop mortality was trending towards being lower in the mini thoracotomy group compared to those that had the mini sternotomies or the conventional sternotomies. And therefore, we think that minimally invasive aortic valve replacement is a safe and effective alternative to conventional sternotomy. Those are references, and thank you very much for your attention. I'll take any questions at this time. Sure, thank you for your question. I think that overall the learning curve is certainly there. In terms of the experience that we had, we saw that one, the chief of surgery that came in who had mastered the techniques was disseminating the technique to the rest of our surgeons at the institution. And you can see that there was a learning curve. I think that's probably what led to sort of the times that I showed in terms of the cross-clamp and bypass time, and those numbers have clearly come down at this point. So in terms of difficulty, it's hard to answer that question, but I do think that overall some of the data does support that there was in fact a learning curve. And I think at this point it's gotten much better. Thank you. Yes, sir.
It's very nice, the study, looking at all three approaches. I'm just curious if you had to modify any of the myocardial protection techniques for the various approaches.
Typically not. I think those were all maintained the same, and that was not a confounding variable in terms of our study. That was all the same. But do you guys do something different in terms of your?
No, we don't do
Not at all? Okay, fair enough.
Said that was for the, and did you know about our online streaming that we're doing? Let me see here, put on.
Yes, yes.
Yeah, no, okay. But we're doing online streaming to a
No,
website?
online, no.
Okay,
No,
that's
no.
why I'm asking.
No.
That's why I'm asking. That's why I'm asking.
Ты брось. Опа. Опа, засада. Так. Я тоже. Сейчас не торопись тогда. Что ж такое?
Okay,
Thank you.
I'm pulling a switch of the computer. So, keep it in over there. Get my remote control set up. Okay, well, thank you very much for having me. I want to thank the organizers and thank Sergei Suchkov for putting me in this workshop. I would like to start off by asking how many people here are clinicians. Can we have a show of hand for the clinicians in the group? Really, so very few, actually. I had assumed that there was going to be a lot of cardiologists here, clinical cardiologists. Well, that's good. Okay, so I'm not a clinical cardiologist either. I'm a PhD researcher. But I'm going to start off with a case history, which I don't usually do. Case history, a woman in her early 50s presents with recurrent pneumonia of unknown etiology, refractory to treatment. And to make a long story short, after a lot of attempts at treating her, she is diagnosed with lung cancer. And she's considered a no-option patient. She's enrolled in a clinical trial of a relatively new drug, Iressa. This year is 2002. So Iressa is an EGF receptor inhibitor that has shown promise in Japanese clinical trials. So she's put on this drug. They try this of treatment. She does not respond to it. She goes downhill, and she ultimately succumbs to the disease in 2003. Now, a good candidate for this drug because she had the correct mutation in the EGFR receptor. She's a woman. Those were considered both features of people who would respond to the drug. However, around this time, it turned out that while it was promising in Japanese studies, it was not very effective in Western trials she was in. And what it turned out a year or two afterwards is that it worked better if you were of Asian origin than if you were not. She was Caucasian. This case presentation, you know, I don't usually give case presentations because I'm not a clinician, but this woman was my aunt. And so I'm actually not giving a case presentation as a clinician, I'm giving a case presentation as a family of a patient. The point of all of this, however, is that I didn't realize it at the time, but I was witnessing a step in the evolution of personalized medicine, which is what we are talking about here. In personalized medicine, the concept that you can tailor treatments to people based on their genetic makeup and other factors. Now, I'm oversimplifying the Iressa story a little bit. There's more to it than that, but I think those are the points that I want to get across to what we're going to talk about. And you've been hearing a lot about personalized and precision medicine recently. It's been gathering steam for many years, and this year is really a watershed for the concept. Actually, President Obama just launched a few months ago Precision Medicine Initiative. And as a matter of fact, as I was on the plane coming here yesterday, I checked my email from the plane and saw this, the announcement from the NIH, request for information, NIH Precision Medicine Cohort. So I think you're going to be hearing a lot about this precision medicine, personalized medicine in the coming years. So let's talk about what this is. So precision medicine, you've heard me say precision medicine, you've heard me say personalized medicine. In the title of my talk, I believe I called it predictive and personalized medicine. My friend Sergei Suchkov likes to talk about predictive, preventive, and personalized medicine, or PPPM, and as some of you know, this is a real thing. There are organizations devoted to PPPM, journals for PPPM. I guess you could put the whole thing together and get predictive, preventative, and personalized precision medicine, but you see where this is going. I mean, you get the concepts of this. And so we have come a long way from decades ago, where really the best that medicine could do, if a patient presented, you say, okay, here's the patient has this disease, we're going to treat the patient with this therapy, period. A number of decades later, it was, okay, here's the patient's genetic test results. the patient is predisposed to getting this disease. And if the patient gets this disease, we'll treat with this therapy. Now, these days, in the last few years, we have, here's the patient's genetic makeup. Not only is the patient predisposed to getting this disease, but the patient, if they get that disease, the patient will respond better to therapy than that therapy and won't respond to that other therapy at all. So that's where we hope to be now and in the next few years. And so what happens if we take this forward into the future? Well, I imagine that in the future it's going to be, here's the patient has this disease, now he doesn't. But I think we have some ways to go to get to that point. And so we are bridging that here with the trying to figure out how to tailor the therapies to the patient to give the best treatment possible. Okay, well, there's a caveat, though, because when you hear about this personalized precision medicine, probably the thing that you think of is genomics, right? We know the genetic makeup, but there's more to it than that. And basically, the message is that genomics only goes so far. And I want to make a pitch that in addition to having the need for a personalized medicine to understand the person's genetic makeup, the age and disease state of the person is important as well. And so, especially in the case of cell therapy, particularly autologous cell therapy, where the patient is getting his or her own cells. And if you think about that, it's because in this case, the patient is the medicine. You're taking part of the patient and giving it back to the patient. So the concept that age and disease state is important to determine how a patient will respond to a therapy, that's old hat. We've known that for many years. But in this case, you're actually treating the patient with bits and pieces of the patient. So you can see where it's going to be important to see how the age and disease state will affect not only the patient's reception of therapy, but also the ability of the therapy itself, the efficacy of the therapy itself. Pardon me. So I want to illustrate this by going into an example from my own lab, the sort of things that we've been doing. And other labs have been approaching similar problems, but this is just to give you an illustration of how age and disease state can affect autologous cell therapy and the need for a personalized medicine approach. So one of the things that we've been interested in my lab for many years are a particular category of cells, circulating angiogenic cells, which if you haven't heard of before, you've probably heard of them as endothelial progenitor cells, cells that were initially thought to be bone marrow derived, circulate, and differentiate into endothelial cells. It turns out that a lot of these cells that people have been studying don't actually turn into endothelial cells. They do have proangiogenic features and qualities, and so a lot of people in the field now refer to them as circulating angiogenic cells, or CACs. And we've been interested in the effect of the age and disease state on the endothelial nitric oxide synthase dependent therapeutic potential of these cells. And I could give a whole hour-long seminar about these cells, but I'm not going to do that because that's not the point here. I want to explain how these things are being affected by age and disease state. So I'm really going to give a very abbreviated background. And first, I want to acknowledge in the work I'm going to be showing you, these are the people in my lab currently and previous lab members who have contributed and collaborators who have contributed. Sergey is on here. We've had a lot of discussions about this. So, oh, and there's my lab. I also wanted to mention I have relevant research funding in the past from Mars Symbioscience and N30. So it's known, and I'm going to go through several years of many people's research, many labs' research in one slide, and I don't mean to de-emphasize any of their contributions, but what you should know is that the number and function of CACs has been seen to correlate with cardiovascular health. The CAC number is reduced in coronary artery disease patients, the CAC function in culture, various functional abilities of the cells, correlates inversely with the risk score. The CAC number actually predicts cardiovascular events in CAD patients, and the function of the CACs inversely correlates with donor age. So you don't have to memorize all this. There's no test about this, but I think you can see just a general idea that there is a correlation between these CACs, function and number, and the health state of the patient. These also have been shown in a number of animal models to have therapeutic properties, regardless of how it works, even if they're not turning into endothelial cells. They can be delivered to, say, models of peripheral limb ischemia, pulmonary hypertension, things like that, and have therapeutic results. And what we've done in my lab is we've looked over a number of years at what these cells do when you inject them into the heart post-MI in rodents, in immunodeficient mice. And so I had assumed everyone was going to be cardiologists, just in case there are people who are not cardiologists. Ejection fraction, EF, is a measure of the heart's ability to squeeze blood out, so a higher number is better. So let's just make sure we're all on the same page about that. If we take CACs, human CACs, and we inject them into the myocardial wall of a mouse heart post-MI, and I'll talk about that a little bit later in the second talk that I give, we've showed that if we inject buffer, the cardiac function goes down over a month, and if we inject the CACs, the cardiac function goes up or is preserved over a month. And what we decided to do several years ago was to ask, okay, so given that these cells correlate with, their function correlates with the disease and age state of the person, how does that affect their ability to be therapeutic? And so we asked, how does the CAC function vary with age, gender, and CAD, coronary artery disease? Do the differences involve endothelial nitric oxide synthase, which seems to be a central player in the function of these cells? If there are these ex vivo functional differences, that is, differences in culture, are they reflective in the therapeutic ability of these cells, such as what I just showed you, in terms of their ability to help the heart after MI? If you have cells that are poorly functional and poorly therapeutic, can they be rescued with eNOS gene therapy? And conversely, just for scientific purposes, can you take the cells that are good and very therapeutic, can you make them less functional and less therapeutic by knocking down eNOS with siRNA? And so we recruited 40 people, healthy women under 45, healthy men under 45, healthy older people, coronary artery disease patients from the cardiology clinics. And we showed, and I'm not going to spend a lot of time on this, but their endothelial function confirmed what we would have expected to see. A number of people have seen this. If you measure endothelial function, it goes down with age, it goes down with coronary artery disease. So when we take these cells out now and look at them in culture, and these, I should say, by the way, are peripheral blood mononuclear cells that you get by culturing an endothelial medium for a week. They're the cells that remain adherent, that become adherent, the cells that were not initially adherent that become adherent within that time. So these cells are frequently tested functionally by checking to see how well they migrate towards VEGF or other angiogenic signals. And indeed, the cells in older people, the cells in coronary artery disease patients did not migrate as well to VEGF. However, we also did control experiments where we left out the VEGF and looked at the ability of the cells just to migrate at random, and we saw the same thing. So actually that was an interesting finding, because it turns out that the ability of these cells to migrate to VEGF that goes down with age and disease state, it's not VEGF specific, it's just their ability to move, essentially. We also showed that these cells, that endothelial cells, if left to their own devices in culture, will form tubes, capillary tubes in culture. The CACs won't do it, but they'll incorporate into endothelial tubes. However, and this was a modest but significant difference, you go down with the older coronary artery disease patients, the cells didn't incorporate into the tubes quite as much. So we're seeing these various functional differences based on the age and disease state of the patient. Now, central to what I'm going to show you in the mice, when we looked at their ability to produce eNOS transcript, so looking at the RNA, we saw a disease-related decline in RNA transcription. When we looked at the protein levels, we saw one that really broke with age. The older people had less eNOS protein in the cells than the younger people. And not surprisingly, those cells made less NO. And so you can see that there's going to be a functional problem with these cells, anything that relies on eNOS and nitric oxide. So again, to make a long story short, when we did the number crunching, the main correlations that came out were that intrinsic migration and eNOS protein level were correlated. So we took all 40 of these people's isolates and we ranked them according to the most functional down to the least functional. We took the 2 best functional isolates, the 2 least functional isolates, and we implanted them into mice. And so in this graph, each group, each line is a group of mice, an appropriately powered group of mice, where the entire group has gotten cells from one person. So it's one patient per group of mouse. And if you inject buffer, cardiac function goes down. If you inject the 2 most functional isolates, cardiac function goes up. And if you inject the 2 least functional isolates, which by the way both came from the patients, these came from 2 young healthy women These came from 2 older patients. And if you injected those 2 isolates, they were maybe a little bit therapeutic, but they were clearly impaired therapeutically. So then we took the worst one and we transduced it with an eNOS adenovirus. So here you see increasing amounts of eNOS protein. And we also did a GFP virus control. So we're now looking at untransduced, control transduced, and eNOS transduced cells. We see that the one that was transduced to overexpress eNOS now produces more nitric oxide in culture, which makes sense. The one that was transduced to express eNOS now migrates better in culture. And when we put them into the mice, the isolate that was poorly functional without eNOS transduction, the same isolate, was more therapeutic with the eNOS overexpression. So we've actually compensated, at least partially, for a patient-specific problem in those cells. And again, just for scientific purposes, just to see, we took the most functional isolate and we knocked down eNOS with siRNA virus. And so we can't see the eNOS band in CACs, so here it is just showing you with HUVEX that this is the knockdown works. So here's the result. That highly functional isolate now produces less eNOS, less NO in culture, migrates less, and when we put it into the mice, here's the therapeutic ability of those cells before, here's therapeutic ability after the eNOS has been knocked out. So we've gone both ways now. So basically, to summarize this has been an illustration of an example where autologous cell therapy was clearly dependent on the age and disease state of the patient, and having nothing to do with the patient as a recipient, because the recipient was a mouse. It was a difference in the cells themselves. And so this calls for the ability to use a personalized medicine approach if you're going to do autologous cell therapy. Now, I want to mention that this is clearly a model system. There are other problems associated with using cells that you need to culture for some time to deliver to an acute MI. So that's definitely true. But I think that this is a good example of how a personalized medicine approach is going to be important in autologous cell therapy. So I'm going to just quickly summarize what I've shown you. CACs exhibited better overall function if they came from younger, healthy people. The eNOS levels and the NO production was correlated with the function ex vivo. This was all reflected in the therapeutic potential for use in a mouse. The poorly functional CACs could be rescued functionally and therapeutically by eNOS transduction. And the functional healthy donor CACs could be impaired both functionally and therapeutically by knocking down eNOS. So I'm going to stop there for this talk and take any questions at this point, if you have any. Yes? Thank you. Question? Yeah, we haven't done that. There are a number of different strategies to increase eNOS, and actually one of the groups, the Dimmler and Zeyer groups in Germany had tried using an eNOS transcriptional activator, and that also helped. Although one of the problems with pre-treating cells in culture is that the effects are going to be transient. So this might be the best you can do in a case like that, but I think that the ideal way of going about this would be a permanent change in the cells by transduction. But clearly, I saw a paper recently from a couple of years ago that had somehow missed me, where they were treating cells with osteopontin, the same CACs, treating with osteopontin to try to increase their ability to participate in wound healing. So I think a number of people are now looking at different manipulations of cells to be used for autologous cell therapy. Oh, absolutely. Yeah. Right. It's an interesting thing to look into. Yeah, thanks for the comment.
I have a question. In this context, do you think there is any specific advantage to ENAS versus, let's say, INAS for achieving the same effect? Because the effector molecule is nitric oxide. Now, INAS is known to be more effective at inducing B cells.
Right.
So, do you think there is a reason for using ENAS versus INAS, or would you consider?
Well, so the reason that we used ENOS here is because it was an ENOS deficiency that the cells had. And in a previous study, we had actually done a smaller study that we published in 2010, comparing CAD patients and healthy people and looking at the CACs. And when we did that, and we noticed that the CACs from the cardiovascular disease patients were producing hardly any ENOS protein, one of the reviewers of the paper asked about INOS. And so we went ahead and we looked for INOS, and we found that there was no INOS differences between the cells from the healthy people and the cells from the patients. And so really our choice of ENOS is simply a matter of trying to put back what is deficient. But again, if your goal is to increase nitric oxide production from the cell, then there are a variety of potential strategies to do that. Yes?
Could you just give us an update regarding the efficacy of CACs that
Well, it's tough because the nomenclature, and this gets into that hour-long seminar I was talking about. I actually took out a slide because I thought I was going to run over, where I showed a parade of names of all sorts of different names that people have been using for the same cells, and that have also been used for different kinds of cells. That the nomenclature of the field has been very, very difficult. And so when the groups in Germany first started doing bone marrow cell therapy trials, which I will actually talk about in my other talk, they initially, in their pilot experiment in humans, they looked at bone marrow-derived cells, and they also looked at cells that I'm pretty sure were these. It's kind of hard to tell because the nomenclature, the preparation is slightly different, but I'm pretty sure were these. They saw better results with the bone marrow cells than with these cells, and in the larger trial that they proceeded to carry out, they focused on the bone marrow cells. So I don't think that for the heart specifically, the CACs do not appear to have been followed up as far as I know. There's certainly a lot of experiments with CACs for peripheral ischemia, and so there's a Japanese group, for example, that's going to town with this. They're delivering to patients with leg ischemia, and I'm not actually sure what the final results of those are.
Any other questions, maybe comments?
And I'll be back for a second talk. It's a long story. Thank you for your attention.
Thank you so much. Matt, let me give you a award
Thank you very
for
much.
your personal contribution.
Do I get 2 of these because I'm giving 2?
of practical healthcare services, predictive, preventive, and personalized medicine as applicable to cardiology. And but, you know, over the course of its history, medicine has given special attention to the already diseased individual, focusing on a type of a disorder, rather than on one's health or so-called pre-illness conditions, the latter being left in the state. The link that might exert reliable control over morbidity, mortality, and disabling rates and significantly optimize the cost of treatment for those who had fallen ill. And the name of this link is appearing now to be the predictive, preventive, and personalized medicine. It's very interesting. It was in 24th at NIH. It's the first workshop in PPPM in the world, held at NIH under the aegis of the director. To achieve the practical implementation of PPPM concept, it's necessary to create a fundamentally new strategy based upon the priorly so-called subclinical, not preclinical, subclinical recognition of biomarkers of hidden imbalances and defects long before the illness clinically manifests itself. The strategy would give a real opportunity to secure preventive measures whose personalization could have a significantly positive influence on demographic. This is just a list of impacts of PPPM to be translated into clinical practice. Sorry, very brief. Human cardiovascular disease is a consequence of a complex interplay of genetic, epigenetic, and environmental factors. Conventional cardiology attempts to prevent disease by modifying the established risk factors and to treat manifest disease, often after complications have occurred and irreversible tissue changes have taken place. Current therapies, for example, those for heart failure, are administered uniformly across a heterogeneous spectrum of disease etiology, severity, genetic background. Now we have the opportunity to expand our medical armamentarium to include molecular phenotypes, so-called signatures, that distinguish subtle subclassification of disease and allows us to better tailor both prevention strategies and conventional therapeutics. PPPM is thus the big change us to predict and to thus prevent is rooted in a big and new science to be rooted from the achievements of genomics, proteomics, metabolomics, and bioinformatics, which are being implemented now into the daily practice to secure visualizing of lesion facie that was previously unknown to clinicians. It's just the illustration. Bioinformatic tools and in reality, genomics as a set of molecular tools to probe genome and to thus identify and to select genomic biomarkers has allowed for identifying new genetic variations that affect health to form subclinical and predictive risks to be screened and unveiled, and then the subclinical pathology to be diagnosed, monitored, and terminated to prevent illness. A set of genomic technologies. Over the last decade, GWAS as a technology have identified many loads associated with late onset cardiovascular diseases, including coronary artery disease and correlates of myocardial function. Genetic loads with multiple trait association have also provided novel biological insights. For example, of the 46 genetic lots associated with coronary artery disease, only 16 are also associated with conventional risk factors for cardiovascular diseases, whereas the remaining 2/3 reflect novel pathways. Genes can say a lot about an individual predisposition to a disease, but we don't know what's happening in protein level. This is proteomics. But a combination of genomic and proteomic biomarkers are becoming of great significance to predict risks, in particular not combinatorial risks of the chronification and thus of disabling, since chronic cardiovascular diseases are preceded by a long subclinical symptom-free phase or a period of latency. It's just in reality. Proteomics and functional genomics are intertwined. Metabolomics, the latter, illustrates the functional state of the cells at the level of metabolism on a real-time basis. Tissue-derived information we would accumulate might be combined with the individual medical records, family history, data from imaging, I mean molecular imaging, instrumental laboratory tests to develop personalized and preventive treatment protocols. But in this sense, how is the whole data bank provided by omics technologies could be comprehended? It's bioinformatics. As a result, the patient becomes a data carrier. It's the principal new entity in the traditional and the canonical medicine. Whilst learning about possible risks of a disease, and the physician can reasonably select a kind of preventive and personalized protocol rooting from the predictive assay made. It's just the illustration of sorry. Thanks. Individuals selected in the first genotypic stage undergo the second stage, which uses a panel of proteomic metabolomic biomarkers whilst monitoring every potential patients, but more interesting, persons at risks, predisposed to the disease, and persons at subclinical of the disorders. PPPM will require the integration of clinical information, stable and dynamic genomics, and molecular phenotyping. In the era of personal medicine, there is increased interest in the incorporation of individuals' biomarkers in risk score algorithms in order to improve cardiovascular risk stratification, followed by the prompt of preventing measures whilst evaluating and prognostic value of currently used markers. I mean, as applicable to cardiology, just you would see it. As well as promising future biomarkers like copeptin, choline, and lipoprotein-associated phospholipase. For instance, galectin-3 is an active biomarker of mortality. Galectin-3. Meanwhile, ST2 is just an example, is released by stressed cardiac myocytes and also predicts mortality in myocardial infarction, ST2. Copeptin is a stable arginine vasopressin precursor with increased risk of heart failure to be used to exclude acute, including secondary acute myocardial infarction. Most of the latter are directly associated with development of atherosclerotic cardiovascular disease. So we would need absolute proofs to confirm clinical applications of the biomarkers mentioned, evaluating not only their diagnostic and prognostic values, but also their integrability into routine practice. Also, a single biomarker is a tangible entity today, that can be easily understood. Aggregate measures comprised of multiple genes are also informative, and the combinatorial biomarkers. The simultaneous addition of combinatorial biomarkers of cardiovascular substantially improves the risk stratification for death from cardiovascular causes beyond that of model that is based on the established risk factors. And clinical potential may be evaluated by asking three fundamental questions. Can the clinician measure the biomarker as applicable to cardiac diseases? Does it add new information? And does it help the cardiologist to manage patients? The incorporation of multiplexed but consolidated biomarkers mentioned into clinical practice for the prediction of death from cardiovascular causes could be accomplished quickly, since the measurement of those biomarkers is already well established for diagnostic use. This is just an illustration of the implication, significance, and valuability of different combinatorial and simple biomarkers. MMP1 in sera, molecular imaging as applicable to cardiology is just a scheme illustration potential targets to be used for molecular imaging, including reporter genes. MRI of, it's just an example, MRI of human thrombi using fibrin targeting peptide conjugate. Look, acute cardiomyocyte necrosis is a crucial step in the life and post-life in the fact that heart generates damage-associated molecular patterns. Look, it's just an illustration of DAMP. The geometric, functional, and molecular alterations associated with post-infarction remodeling are driven by the inflammatory cascade and are involved in the development of heart failure. So we would have to treat, but better to prevent. The implementation of cardiovascular prevention strategies continues to reduce the incidence of myocardial infarctions. What should we do, and which kinds of the prevention protocols should be exploited? Prevention can be divided into three types. Primordial, prevention of risk factors. Primary, treatment of risk factors. And secondary, prevention of recurrent cardiovascular events. It's just therapeutic illustration of therapeutic potential of HDL in cardioprotection and tissue repair, very briefly. This is an MMP, a whole family, huge family. At least 3 from this huge family have been already translated into clinical practice as applicable to cardiologists. MMP2, for instance. Targeting B cells in atherosclerosis. Plaque formation is strongly influenced by different arms of the immune system, including B cells affiliated arm. Okay. Meanwhile, regenerating the human heart is a challenge that has engaged clinicians around the globe for nearly a century. Look, the human heart harbors an adult stem cell population consistent with true characteristics of stemness, such as self-renewal, clonogenicity, and multi-lineage differentiation potentials. It's like an entity. Adoptive transfer of human cardiac stem cells results in modest repair due in part to lack of survival, proliferation, and commitment of the transplanted cell after myocardial infarction. For instance, transplanted human CD34 have been proven to become very valuable to be used in the preclinical experiments. It's just an illustration of the latter. Okay. Okay, it's just an illustration. Okay. Genetic and pharmacological priming together with the discovery of new sources of cells have led to a second generation of cells products that holds an encouraging promise in cardiovascular regenerative and preventive medicine. And due to the novel nature of cell-based therapies, it's evident that the cardiac clinical community will play a critical role in their successful adoption. Meanwhile, implementation of PPPM, including into the cardiac area, would require the adjusted technology for proper interpretation of diagnostic and predictive data before the current model physician-patient, cardiologist-patient, could be gradually displaced by a medical advisor, healthy person at risk model. This approach should be based on postulates which would change the incarnate culture and the socially mentality. And no doubt, for me, no doubt that you would just get it read yourself. Thank you so much. If any questions, I would be very happy to provide the feedback. Okay, thank you. And now, there was a small gap in our understanding of stem cell and stemness as applicable to cardiac practice. And let me introduce Professor Galina Bilastotska, who has done a lot for her personal trying to get this gap filled.
cell therapy of cardiovascular diseases is not possible without basic, fundamental biological knowledge about the physiological and regenerative processes in the heart muscle. However, despite all the fact that the self-renewal of myocardium, mammalian myocardium, is widely recognized, it is not a definite answer to the key questions: what cells and how produce new cardiomyocytes in disease and in health. The data about the differentiation of pre-existing myocytes and the possibility that post-mitotic myocytes can re-enter cell cycle and divide have little basis. But the possibility of transdifferentiation of hematopoietic cells into cardiomyocytes are active fast, and despite of some controversy in results. In turn, current data, in vitro and in vivo data, suggest that cardiomyogenesis is achieved via activation and differentiation of endogenous stem cells. But there is little information about details of this process. We know that in myocardium there are several types of stem cells. This is scar, CKIT, islet, and they could produce new cells, stem muscle cells, cardiomyocyte, and endothelial cells. And they, how not finitely suburb introduced into myocardium. We previously shown that newborn rat have resident stem cells, three types: islet, CKIT, and scar, and which are able to form colonies, clone from one cells. And then this is information from newborn and 20-day-old rat. During the cultivation, the clone of cells became differentiate and became to contract. Now you can see the contraction of cells inside the colonies. It's very interesting that the rate of contraction increased from 2 beats per minute, and on the 8 days till 60 minutes per minute, 60 beats per minute at the end of month. Here it's possible to see that cells, cardiac stem cells of islet type form a colony of endothelial cells. And here it's possible to see some vessels which grow from this colony. And marker, islet, and CD105 show that this is endothelial cells from islet stem cells. Besides results in vitro, we determined that the similar is possible to see in the suspension of mammalian cardiac cells. This is ex vivo experiment. You can see a small clone from 3 stem cells. This is some more large. This is a compact, small clone from scar cells. And here there is data from a rat, mouse, rat of different age, and even from a human myocardium. This picture. It's necessary to say that clone formation appears to be one of the main mechanisms of cardiomagnetic differentiation stem cells, renewal of myocardium. But it's necessary to say that this conclusion is quite expected and is in line with existing ideas. But in spite of the ability to form new heart cells, cardiac stem cells don't make an appreciable contribution to the restoration of damaged myocardium. In this regard, our data about the intracellular development of cardiac stem cell allow to look at the problem from angle. For the first time, we demonstrated that cardiac stem cells are residing inside mature cardiac myocytes, forming specific cell and cell structures. The formation of such structures was described in hematopoietic, immune, tumor, and other cells during such processes as peripoiesis, endosis, phagocytosis. But we first identify cardiac stem cells inside mammalian myocyte. Here it's possible to see that stem cells with own nucleus is situated near nucleus of host cells or between two nuclei, near or between. During the cultivation, such one cells which began to divide and form some similar clone have a vacuole surrounded her, and it's here clear. It is clear here, vacuole. But later, wall of this vacuole became thick and rigid, and this is resemble situation of endosis, when cell and cell structure have such view, and cell inside cell, host cell. And the fate of these cells is death, division, or escape. In our experiment, we showed that stem cell or several stem cells are between filaments of cardiac cells. In the culture, we received several variants of such structures formed by the kid islet cells in newborn rat and 30-day-old rat, and they have interesting peculiarity. On the membrane of capsule, there are 3 till 5 openings. Some special pore. We propose that they need for cross-talking between cell, host cell and stem cells. Here we demonstrate that such structure express the marker of division, Ki67, and you see they have clearly, you see open on the capsule here and here. During the cultivation, the size of such structures became more large and became volume. In this, you can see the scanning of cell and cell structure of 30-day-old rat. It's possible to see that nuclei, 2 nuclei of host cell are inside this capsule. The middle size of this structure is 46 micrometer. And here I show you the scanning of cardiomyocyte, a single cardiomyocyte of 20-day-old rat. And you see, and I name this structure the pregnant cardiomyocyte. The capsule, this is not very big. This is only beginning of this process. The D max is 83 micrometer. This is rather large cardiomyocytes, and structure only one third of this size. And what is the fate of this structure? During the cultivation, we can observe that this structure is ruptured and open, and some cells which past division inside host cells, they go out from capsule. This is added in this picture. You have added type. Here you have many cells which came out from such structures. Here it is see that cells which we name as transitory amplifying cells have two marker, c-KIT and sarcomeric activity. Therefore, we propose that during the development, stem cell not only divide, but also partially differentiate. In this, in this picture, I don't see good with me. We have, it's possible to see in a very small local region, it's possible to see near 200 transitory amplifying because the presence, we know that only one stem cells is present for 100,000 of cells. To see 200 cells near each other, it means that they came from one source, from one source. Yes. And here it's possible to see that they, when they go out, they are in special muscles, gale structure. And after this, they go separately. And here I demonstrate you the process of opening such structure. See attentively. Here is represented the same object after fixation and immunostaining. It's possible to see this is troponin positive cardiomyocyte and islet stem cell. Here are represented such structures in freshly isolated cardiac stem cell suspension, ex vivo. This is old rat, adult mouse, and cattle, bovine. Rather adult animals. Here, different variants of human cardiac cell and cell structure. Human. This is data of woman of 45. You see the same picture as earlier. Also several opening. And also you see nuclear and some of such structure are open. Now, after demonstration of these results, if you allow me, I show my ideas concerning for what it needs. I suppose that of new cardiomyocytes is possible by two ways: by clone formation and by formation of intracellular structure. Both this way they have the same rate, one event per 100,000 of cells. But if we analyzed results of our experiment with simulation of situation in infarct zone, when there is acidosis and different inflammation, the situation changed. Clone formation stopped, but the formation of structure increased in 10 or 15 types. And it is, I think it's possible, because aggressive medium where cells are during infarct, they side inside cells. To protect himself from aggressive medium. And therefore, we cannot see the progress of new cardiomyocytes because clone is not produced, but cells hide inside mature cells. This is a situation which is necessary to know because the attempt to stimulate stem cells for division, for differentiation, is not a success. This situation during ischemia and infarct, stem cells don't work. Yes, what I want here. Yes. Yes, there is one moment when we provided experiments with behavior of stem cells during microgravity. During microgravity, the situation changed another way. Became more clone and not change the number of cell and cell structures. Because during microgravity, we have no inflammation, we have no acidosis, we have no aggressive media. And therefore, clone formation became the main way for formation of new cardiomyocyte. Thank you very much.
Thank you so much. It was so much difficult to ask Galina to come here, but we have succeeded to having her here. And any questions, any comments, maybe suggestions for getting
interested in bone marrow cell therapy for MI, and we're looking at the impact of age and MI on that promise. And that this, in the title, this patient-specific bone marrow cells, I'm not actually going to be talking about patient-specific cells here. We are working on patient cells, but this talk is actually going to be about our results looking at rodent cells, and you'll be able to see the promise and the implications for the human. So again, for this project, here are the people in the lab and the previous people who have helped out. There are no disclosures for this talk. And so just a quick summary of bone marrow cell therapy. When people first started talking about stem cell therapy for the treatment of MI, a lot of the discussion, a lot of the focus then was on cells from the bone marrow that were assumed to be adult stem cells that would transdifferentiate into cardiomyocytes. And the people would get, this worked in rodents, and then in people since 2006, they were getting their own bone marrow cells taken out and put it into their hearts, and it seemed to work. However, there was a question of how it works, and for a number of years, this was a very heated debate. I don't know, for the people who are here from Philadelphia, I would say that the debate here was almost as heated as the Pats versus Geno's and provolone versus Cheese Whiz debates in Philly. But for those of you who don't get that reference, ask a Philly person. But I think that the consensus ultimately was that there are cells in the bone marrow that can adopt a cardiomyocyte fate, but they don't appear to be doing that very often. And whether that was really relevant to the therapeutic effect of implanting bone marrow cells or otherwise delivering bone marrow cells in the heart, that seems to be a different story. When it got into the humans, however, the question really turned into, does it work? Because the results in the human trials were modest, they were mixed, they weren't nearly as robust as what we and other labs could see in the rodents, where this really worked quite well. So what we did, and I'm going to go through a big project in one slide here, because we published this in 2009, and this is background for what I want to tell you about. But basically, my collaborators and I at UCSF a number of years ago, we set up a system where we would implant bone marrow cells and unfractionated bone marrow cells from mice into the hearts of mice post-MI. And we did something a little differently from what most people were doing, which was that we guided the injection into the heart using ultrasound, which did not require surgery to open the chest. So we could induce MI surgically and then come back several days later without a second surgery and deliver the cells. And this was more relevant to the timing in the clinic. And what we saw is that, and here's your ejection fraction graph again, we saw that again, if you inject buffer in here to the myocardium, cardiac function goes down. If you inject bone marrow cells, cardiac function goes up or is preserved. And in a number of ways, we looked at infarct size, we looked at vessel density early on, we looked at cardiomyocyte apoptosis in the area at risk, and it seemed that this was a beneficial treatment to all of those properties. However, remember, people were expecting these to be stem cells, right? We delivered cells that were from genetically labeled mice, green fluorescent protein labeled mice. And we saw that very few of the cells were still present at 28 days after the therapy. And of the cells that were there, none of them were cardiomyocytes, none of them were endothelial cells. They weren't really anything unexpected. And we also saw that when we killed the cells first and injected a cell-free extract, that's what this is, it was therapeutic as well. So we concluded from this that this was clearly not a stem cell mechanism, this was clearly a paracrine mechanism, and the cells were basically just dying or secreting growth factors. We published this in 2009 in Molecular Therapy. Now, the reason that this is relevant to this personalized medicine concept that we're talking about here is that, remember that this works very well in rodents, and you can really improve cardiac function in the rodents, but it wasn't working all that well in the humans. And what we realized is that there was a fundamental difference between the mouse experiments and the human experiments. In addition to the fact that they're different species and they're different models, et cetera, big difference was that in the rodent experiments, you can't take bone marrow out of a mouse without killing the mouse. And so the way these experiments are done is you take bone marrow out of one mouse and you deliver it to the hearts of another mouse, a syngeneic, genetically identical mouse. Okay? And for reasons of feasibility and economics, when people do these experiments, they usually take the cells from young, healthy donor mice. So you can say that these mice are getting young, healthy, or healthy young donor bone marrow implantation. However, when we do this autologous cell therapy approach in humans, the humans they're getting their own cells, they're older, they've had an MI recently. So we're giving the humans old post-MI donor bone marrow cells. But we don't give humans young, healthy donor bone marrow cells, right? And as a matter of fact, we definitely don't give them juvenile young donor bone marrow cells, and that's basically what the rodent experiments are. They're coming from pretty young mice. So the rodent experiments that were working well were not a good representation of what we do in the clinical trials. So we set out to ask what would happen if we took bone marrow cells from older animals or from animals that have had an MI themselves. And in all of these experiments, we would keep the recipients constant. The recipients would always be young, post-MI mice. That way we can only look at changes in the cells themselves. So Xiaoyin Wang, again, is the one that did most of this work. So let me look at the age first, then we'll look at the MI. In the age, Xiaoyin and also a postdoc who used to be in the lab, Junya Takagawa, they implanted cells from young donors, middle-aged donors, about 1 year old, and old donors. And one thing you can see is that the cells from the old donors were useless. So that's not good news for older patients who are getting this therapy. The cells from the middle-aged donors were impaired. They were maybe somewhat therapeutic, but they were impaired therapeutically. And again, for the cardiologists in the audience, if you want to see all this other stuff, basically looking at different functional aspects, we saw incomplete penetrance, but there were aspects of this that were impaired by the age of the donor. So we published this as a very short paper in a small journal, Tissue Science and Engineering. We wanted to get the results out. But subsequently to that, a postdoc joined the lab, Songtao An from China, who drilled down in this more and wanted to see whether this was a progressive change over time. And so he took cells from donor mice that were 10 weeks old, 6 months, 1 year, 1.5 years, 2 years old, compared to buffer. Again, the recipients were always the same. And he saw a progressive change in the ability of these cells to improve cardiac function. And he did all of the other, looked at chamber volumes, he looked at wall thickness, he looked at infarct size. And I apologize because this slide isn't the one I had intended to put in. I don't have statistics in this slide. We did linear regressions on this and we showed significant differences, progressive differences in all of these features. So it seems that over time, the age of the donor mice, the cells were getting less and less effective. So hang on, hold that thought. Now what about donor MI? In one sense, it's not surprising that as you get older, your cells aren't as good, right? But donor MI, 3 days after the MI, cells are taken from the mice and given to other mice at 3 days post-MI, and those cells were not as good. They were impaired. And so we have to try to figure out what happened. It was a partial response. We had a modest difference here in end systolic volume, which probably accounted for that. We got, again, it was not as strong of an effect as the age, but in repeated experiments, we kept seeing the same thing. Our ejection fraction was always somewhat lower. So let's take a look at that. And everything I'm going to show you from here to the end of the talk, we published in Science Translational Medicine a few years back. So we've seen an effect, and we have to ask why. What is happening since MI? MI is a very pro-inflammatory event. You get lots of inflammatory cells in the heart, and those cells clearly are come from the bone marrow. So it makes sense that if you take bone marrow after an MI, it's different bone marrow. It's pro-inflammatory bone marrow. And so somehow we hypothesized that was probably affecting the ability of these cells to be therapeutic. So there's a lot of stuff on this slide. I'm just going to give you the bottom line from this. We looked under various ways to find out, to confirm that inflammation was in fact occurring here. And we did see a number of markers of inflammation. We saw it in the spleen, in the blood. Notably, we saw a reduction in bone marrow B cells. We saw an increase in MHC2 expression on the bone marrow B cells, reduction in myeloid cells, decrease in MHC2 expression on the myeloid cells. These were all just markers of inflammation. So the take-home lesson from this slide is, yes, after the MI, when we took those bone marrow cells out, they were in an inflammatory state. Now, it had been known from the human studies of MI that the acute inflammatory response comes up over the first few days and then goes down. So we reasoned that if that was responsible for the problem that we saw, then the cells should get less therapeutic for a few days after an MI, and then they should regain their therapeutic efficacy. And so Xiaoyin did a massive experiment taking cells from donor groups at different times post-MI, 1 hour, 1 day, 3 days, 5 days, 7 days, 21 days. And you don't have to try to line up the colors here, because I'm going to take this graph and I'm going to facing you so that you can see what we saw on day 28. Here's the day 28 response. And again, the recipients are all the same. This is the day at which the cells were taken post-MI. So 1 hour, 1 day, 3 days, 5 days, 7 days. So indeed, the cells got less and less therapeutic, and then they got more and more therapeutic with increasing time after MI. We also looked at changes in serum cytokines post-MI, and this is basically a cytokine array showing lots of tiny time courses. Each of these is a time course going from 1 day, 3 days to 7 days. And a number of cytokines came up and went down during that period of time. Again, circumstantial evidence that inflammation is responsible for this. And we even the percentage of inflammatory area in the heart. And we lined all of this up together, and basically here's changes in cytokines, there's inflammation in the heart, there's therapeutic efficacy of the cells in the red line, a big correlation. But it's a correlation, right? It's all circumstantial evidence. So what we did is we said, okay, well, if inflammation is responsible for the effect, then let's try preventing inflammation in the donors. We treated the post-MI donors with methazone, and so here is an EF graph showing the recipient and ejection fraction when post-MI cells, this is a little complicated, when post-MI cells treated with vehicle, in this case DMSO, were implanted, they're still impaired. And here's what happened when we treated the donors with dexamethasone instead. We've restored the ability of the cells to be therapeutic. We took it one step further. Remember I showed you this graph here of all of these cytokines that went up and down. Focus on these. It seemed like the biggest effect was seen in the IL-1, IL-6 pathway. And so we took an IL-1 receptor antagonist and did a similar experiment. We treated the donor mice, the post-MI donor mice, with the IL-1 receptor antagonist, and we partially impaired, or partially prevented the impairment. So what we concluded from this was that there was an IL-1 related signaling from the heart to the bone marrow that was resulting in cells being less therapeutic. And that was all the Science Translational Medicine paper. Now, I am going to take it one step further for you. This is unpublished. We're writing this up. Remember I showed you this picture from the post-MI, right? And again, we weren't looking for mechanism here. This was just trying to show that inflammation was occurring. And I want you to focus in on this one graph. B cells in the bone marrow were lower post-MI mice. Well, we looked at the effects of age on bone marrow composition. And in all of the changes, when we looked at young versus old bone marrow, the one that stuck out was a reduction in bone marrow B cells. So we have post-MI mice, old mice, they both have bone marrow with a lower number of bone marrow B cells. Probably for completely different reasons, but they're converging on this one point. So we said, hey, maybe the B cells are important here, because we've already ruled out stem cells, right? Maybe the B cells are important. And so we took young, healthy donor bone marrow, and we depleted B cells to try to mimic these cases. And interestingly enough, when we did that, we recapitulated the impairment from the old and the post-MI situation. So what we're looking at here is, we think, indicative that the B cells are playing a crucial role, and we're currently doing follow-up experiments on this to try to understand this better. So I think that's all I have for you here. I'm going to conclude, again, summarize what you've seen. The implantation of the bone marrow cells into myocardium 3 days post-MI improves or preserves cardiac function. Advanced age or MI in the bone marrow cell donor impairs this response. The impairment appears to involve an IL-1 signaling pathway, and this may involve B cells, and we're pretty confident that it does. I'll also mention to you that we have reason to believe that this is relevant to humans, that the same thing is going on in human bone marrow. The data are a little preliminary, so I'm not actually going to go into that right now, but I just wanted to say that this is not completely out in rodent space. We feel that this is really relevant to personalized medicine in human trials. We'll be with people who are doing human clinical trials, looking at their cell samples and trying to determine what's been going on. So thank you again. Thanks for bearing with me for 2 talks. And are there any questions about that? Yeah.
Please.
2 questions. I believe it was right before the MI, and then day 1 and day 2. So I think I think it was 3 doses, if I recall correctly. The first one was before MI, and then day 1, day 2, and then we harvested the cells on day 3, I think. No, we haven't looked at the IL-1 antibodies. All we've done with the IL-1 was the receptor antagonist. And that seems to do it. You know, it was interesting. I don't know whether to read too much into these graphs or not. Let me go back to the slide. We'll see what you think. Whoops. Where is it? So I've been reluctant to interpret too much from this, but I think it's intriguing that this was not as complete of a prevention of impairment as dexamethasone, as if, right. Yeah, we don't know. That's a good question. But we don't know that. But we're getting interested in the signaling going on in the B cells, studying exosomes and various factors that the B cells might make. Yeah, yeah. Well, this is why we're still doing the experiments. Thank you.
Any other questions?
What the future of these cells? What the future which
You mean clinically?
yes, which you introduce in the myocardium?
Well, it's a great question. Let me say that the field, if the answer to be believed, the field has moved away from bone marrow cells and no one cares about them anymore. My message is that I think if bone marrow cells just aren't working well in humans, maybe that's the case, but if we have a potential reason why they're not working well in humans, if we can get them to work as well in the post-MI aged state as in the young animals, if we can fix them, then we can try fixing them in the humans as well. And I think that maybe the bone marrow cell, and notice I'm not saying stem cells at all, I'm saying but the bone marrow cell therapy idea could still have legs if we can get around this problem caused by the age and MI. In other words, a personalized medicine approach, defined loosely.
Please.
I have a question about the anti-inflammatory treatment. Do you think it's possible that after an MI, this is kind of thinking outside of the box, but maybe treating with an anti-inflammatory agent, maybe a biologic agent, might in and of itself be a possible treatment?
You mean treating the cells themselves in culture before introduction? Or
Right, or clinically, like when you translate to humans, like in cardiology, that would be the standard of care.
Right. So one thing, and this was kind of amusing. Remember, I'm not a cardiologist, and so but I'm in a cardiology division, and so I would present this research to roomfuls of cardiologists. And when we said we were planning on doing the dexamethasone experiment, there was a chorus of protests. It's like, no, you can't do that, because people tried treating MI patients with anti-inflammatories, and they had cardiac rupture, and inflammation is important. You need the reparative arm of the inflammatory response. We just maybe want to knock out the problem for the bone marrow. You need it in the heart. And so treating the patient with an anti-inflammatory, general anti-inflammatory, is probably not a good idea. So what we're trying to do, if we can pinpoint the kind of signaling involved, maybe we can knock out the specific signals without preventing the reparative arm. And if we can treat the cells somehow in culture on their way back in, that would be certainly acceptable too. I mean, if the problem is B cell related, if there are just not enough B cells, maybe you just need to supplement with more, right? If the problem is the B cells aren't as functional, then maybe you need to figure out why. I mean, clearly we have a way to go. And remember that the lysate, the extract, was therapeutic. So it's still not clear what in the extract is doing this, and if we can ever figure that out. I will say that we're doing an experiment right now, even as we speak, where we're looking to see if B cell lysate is as therapeutic as whole bone marrow cell lysate. So we're pursuing those experiments. Question over there. Yeah, you're getting beyond my level. So I have a collaborator who's our B-cell person who knows much more about B-cells than I do. It's a CD19 positive B-cells in the bone marrow. She seems to feel that they're reasonably mature, but they are the bone marrow population and not the circulating population. And I would worry about saying any more than that because I'd probably be waving my hands in the air, and I might say the wrong thing.
It's okay. We have just discussed that one of the major molecular and cellular tools to be used and exploited in the area of the cardiology of the very future to come. And now we would just imagine and understand clearly that apart from the tools to be used and exploited efficiently, we would need delivery systems. Different generations, different families, and let me introduce Professor Michael Chorney, who would just share with you issues regarding the targeted drug delivery systems, which regards attribute to the nano generation. And we would finalize.
Okay, so I guess we're going to change subjects radically. I'm going to talk about nanoparticles. Well, maybe not very radically, because
Good afternoon, everyone. My presentation topic is on damselin isoform 2 induced nullification of the effect of acetyl salicylic acid in platelet aggregation in acute myocardial infarction. Acute myocardial infarction, like other forms of acute coronary syndrome, is pathophysiologically related to thrombosis that produce infarcts on the pericardium. However, unlike in the case of ACS, the platelet aggregation induced by different aggregation agents in AMI cannot be inhibited by aspirin. Currently, there is no known mechanism of the platelets in AMI to become resistant to the well-known inhibitory effect of aspirin. It is believed that the aggregation in AMI cannot be inhibited by aspirin. The recurrence of AMI may follow within months and the victims may succumb to the condition. In this presentation, I will present the role of a stress-induced protein isolated from the circulation of AMI patient identified to be damselin isoform 2 11 kilodalton small protein, which was sequenced by the help of Harvard University's First Center for System Biology. I would also present its role on the development of resistance of platelets to aspirin. I would present here unique and a simple way to resensitize the platelets from AMI subjects to the inhibitory effect of aspirin through the expulsion of bound damselin from the platelet surface to the increased production of nitric oxide by using low amount of aspirin itself, which, unlike the classical inhibition of cyclooxygenase's activity through the inhibition of prostaglandin. Effect of acetyl salicylic acid on the ADP and other platelet aggregating agent induced platelet aggregation in PRP from normal volunteers and from AMI subjects. For this purpose, two sets of experiments were performed. In set 1 experiment, normal PRP was incubated with different aggregating agents in presence of 80 micromolar aspirin, and in set 2 experiment, AMI platelet plasma was incubated with different aggregating agents in presence of 80 micromolar aspirin. Here, red line indicates that is line A, B, C, D represents the aggregation of AMI PRP induced by thrombin, ADP, epinephrine, collagen respectively in presence of 80 micromolar aspirin, where in presence of 80 micromolar aspirin, aggregation is not inhibited in case of AMI platelet plasma. In the other hand, green lines, that is A1, B1, C1, D1 represents the aggregation of normal PRP in presence of 80 micromolar aspirin, where aggregation is completely inhibited. To understand what caused aspirin to fail to inhibit aggregation in AMI subject, to test this possibility, the PRP from normal volunteers was incubated with 0.4 micromolar damselin for 90 minutes and 37 degrees centigrade, and subsequently 80 micromolar aspirin was incubated for 30 minutes and 37 degrees centigrade. It was found that damselin treated normal PRP did not inhibit the aggregation. That indicates the line A. Whereas in case of normal PRP, where damselin was not incubated, but in presence of aspirin, the aggregation is completely inhibited. Scatter-plot analysis of the equilibrium binding of damselin to normal platelets. To determine whether the effect of damselin on the development of resistance to aspirin was mediated through the binding of the damselin to normal platelets, scatter-plot analysis of the equilibrium binding of damselin was analyzed. On the scatter plot, it was found a curvilinear plot. This curvilinear plot represents the heterogeneous binding site population of damselin on normal platelet surface. One is high affinity, low capacity binding site, and another is low affinity and high capacity binding sites. Effect of incubation of platelet plasma from AMI subjects with damselin antibody and the inhibitory effect of aspirin on the antibody treated platelet plasma. To determine the role of damselin further as the cause of resistance to the inhibitory effect of aspirin, AMI platelet plasma was incubated with damselin antibody for 90 minutes and 37 degrees centigrade, and subsequently 80 micromolar aspirin for 30 minutes and 37 degrees centigrade. It was found that in presence of damselin antibody, AMI platelet plasma aggregation of AMI platelet plasma is completely inhibited. That indicates the line B. On the other hand, normal AMI platelet plasma, where damselin was not incubated, but in presence of 80 micromolar aspirin, aggregation is not inhibited. That indicates the line A. The removal of the bound damselin from platelets from AMI subjects by the stimulation of nitric oxide in platelets. We have reported from our laboratory that damselin is a potent inhibitor of all forms of nitric oxide synthase. The inhibition of nitric oxide synthase in normal platelets aggregates the normal platelets even in the absence of ADP through the production of the thromboxane A2 synthesis. Here, from the figure, it is found that in presence of 15 micromolar aspirin, production of nitric oxide was highest. This nitric oxide cannot inhibit the aggregation, but was able to expel the platelet-bound downstream from the AMI platelet plasma. Here, solid square represents the synthesis of nitric oxide in presence of different concentration of aspirin, and solid triangle represents the release of downstream in presence of different concentration of aspirin. Here, solid circle represents the NAME incubated AMI PRP, because NAME is the potent inhibitor of all form of nitric oxide synthesis, and also inactive the aspirin effect through the production of nitric oxide and in the expulsion of the platelet-bound downstream. Effect of re-exposure of PRP from the AMI subjects to 10 micromolar aspirin on the inhibition of ADP-induced platelet aggregation in the PRP pre-treated with aspirin or insulin or NO in 0.9% NaCl. To determine this effect, AMI platelet plasma was pre-incubated with 0.8 nanomolar nitric oxide itself or 15 micromolar or 13 microunit insulin per ml. It was found that at different concentration and subsequently at different concentration at the presence of 10 micromolar aspirin, the aggregation is completely inhibited. That indicates the line A1, A2, A3. The pre-incubation of AMI PRP in presence of 50 micromolar aspirin. A2 indicates the pre-incubation of AMI PRP in presence of 30 microunit insulin per ml, and A3 represents the aggregation of AMI PRP in presence of pre-incubation of 0.8 nanomolar insulin, 0.8 nanomolar nitric oxide itself. It was found that in presence of 50 micromolar aspirin, 0.8 nanomolar nitric oxide and 30 micromolar insulin can inhibit the aggregation in presence of 10 micromolar aspirin. Whereas line A indicates the aggregation of AMI PRP in presence of 80 micromolar aspirin, where the aggregation is not inhibited even with the presence of aspirin. The effect of pre-incubation of AMI PRP with aspirin, insulin or nitric oxide in 0.9% NaCl solution on the binding characteristics of downstream to platelets in scatter plot. To determine the role of pre-exposure of aspirin, insulin or nitric oxide in AMI platelets, the effect of aspirin, insulin and nitric oxide on binding characteristics of downstream, the scatter analysis of the equilibrium binding of downstream on normal on AMI platelet plasma was analyzed. From the figure, it was found that solid square represents the aggregation of represents the binding of AMI platelet plasma and normal platelet plasma, where insulin, aspirin or nitric oxide not incubated, whereas hollow square represents the hollow square represents the scatter plot in presence of 15 micromolar aspirin, and solid circle represents the pre-incubation of 0.8 nanomolar nitric oxide, and solid triangle represents the scatter plot analysis of the equilibrium binding of 30 micromolar insulin per ml. From this result, it can be concluded that the presence of downstream in the circulation of AMI impaired the aspirin-induced inhibition of platelet aggregation. This result suggests a novel way to treat the AMI via the desensitization of the platelets to aspirin through the generation of the nitric oxide. The increase of platelet nitric oxide level by insulin or aspirin or by nitric oxide itself resulted in the removal of the bound downstream from its high affinity binding sites on the platelet surface. The aspirin-stimulated NO synthesis may have in AMI platelets may have biphasic effect in that the maximal synthesis of NO that will achieve at the 15 micromolar of the compound, and the use of higher doses of the compound actually will result in the decreased production of nitric oxide. And at 300 mg aspirin per 70 kg body weight will reduce the synthesis of nitric oxide with corresponding reduction and removal of the platelet-bound downstream. If this result from in vitro study to the subjects affected by AMI, it might be suggested that the use of 300 mg aspirin is not the optimal dose, which could be induced harmful. Our preliminary data suggested that perhaps the chronic use of 14 mg bolus of aspirin per 70 kg body weight, and after 30 minutes another 9 mg bolus of aspirin per 70 kg body weight might be helpful in the expulsion of the platelet-bound downstream to inhibit aggregation and prevent from the recurrence of AMI. Thank you.
Thank you. I'll take any questions. Take any questions.
Yes. What is the? Aspirin can produce the nitric oxide. It measured by methemoglobin method. Chemiluminescence method. It also, at first it is the amount of production of nitric oxide was measured by methemoglobin method by Beckman's spectrophotometer, and it is confirmed by chemiluminescence method. It is found that nitric oxide production, aspirin can produce nitric oxide, and insulin or nitric oxide can itself produce nitric oxide in AMI platelets plasma, because we found that in AMI platelets plasma nitric oxide production was going to 0, and in presence of insulin or aspirin, production of nitric oxide was maximum at 50 micromolar of aspirin concentration, when 300 milligram aspirin cannot produce the enough aspirin to reduce the to remove the platelet downstream from the AMI platelets plasma, and aggregation is not inhibited in 300 microgram aspirin.
How did you define acute MI?
We found we take the ST attenuated myocardial infarction and non-ST attenuated myocardial infarction, and who have the Q wave, and lastly we found which cross-check the AMI patient by the troponin by ELISA.
So they had to have a troponin positive.
Yeah.
And T wave inversions. T wave.
Q wave and ST attenuated, non-ST attenuated, we take. Who had the Q wave, and lastly we finally take the took the patient who have troponin T by ELISA.
Okay. And then I didn't.
Myself, Tanima Banerjee. I am working under the supervision of Dr. Arun Bandhopadhyay from CSIR, Indian Institute of Chemistry, Kolkata. So, rheumatic heart disease is a chronic acute disorder which results from acute rheumatic fever, and this disease is mainly characterized by ongoing inflammation, which affects the valve, both the mitral and aortic. And mostly the mitral valve is always involved with the involvement of the aortic valve, and it's mainly diagnosed by echocardiography. During childhood, Streptococcus pyogenes bacterial infection, rheumatic fever occurs, which affects the heart valve, in which both the mitral valve and aortic valve get damaged. In our laboratory, we are interested to study on mitral valve, in which both mitral stenosis and mitral regurgitation occurs. mitral stenosis is the narrowing of the orifice of, and the mitral regurgitation is the backflow of the blood from left ventricle to the left atrium. This disease is mainly prevalent in developing nations due to poor nutrition, under malnutrition, and it is by WHO categorized as neglected tropical disease. So our main objective of this study is to investigate whether this extracellular matrix remodeling in rheumatic valve leads to altered levels of circulating collagen metabolism markers, and if such markers can be clinically used to diagnose or monitor disease progression. Valve is composed of fibroblast, and we know that collagens are known to synthesize from fibroblast. Valve mainly composed of type 1 and type 3 collagen, where type 1 is mainly 74% and type 3 is 24%. So if you can see here in this mechanism, during the formation of collagen type 1 from pre-procollagen, the PICPs get released into the bloodstream. So as this PICP is involved in the valve pathophysiology, so we are interested to know there is maybe any correlations in this mitral valve pathophysiology. So we have designed our study. We have taken normal, healthy subjects, those who are not suffering from any kind of disease, and we have taken patients, those who are suffering from rheumatic heart disease, and also the patients who are suffering from rheumatic heart disease after valve replacement surgery also, we have taken some post-operative samples, and for following up those samples, we have taken some randomly collected samples of these rheumatic heart disease. So here you can see we have studied in our Indian subpopulation 42 those who are suffering from mitral stenosis and 30 mitral regurgitations. And follow-up we have did for 1 month and then later on for 1 year. I will show you my next slides. So before start our experiment, we have done some inclusion and exclusion criteria in which we have chosen those samples who are suffering exclusively chronic RSD, and we have also excluded those patients, those who have diabetes, hypertension, renal failure, metabolic bone disease, liver failure, and any kind of severe systemic illness. And also we have not taken those patients whose ejection fraction is less than 50%. Otherwise, these patients could be in an advanced stage which cause overt heart failure. So here if you can see the baseline patient characteristic, here you can see in the male and female ratio, there is female ratio is much more higher in this case samples. Though they belong to NYHA1 and NYHA2 class, these are comes under the case 1 mostly. So as we know that there is in rheumatic heart disease, involvement of the lesion is more than one type. So we have chosen predominantly MR. So here if you can see that we are taking all the parameters of their atrial fibrillation CT, their blood pressures, everything we have taken from with our clinicians. And we have also taken the structural parameters like LA, LVIDD, LVIDS, which is probably indicator for MR, and PSP and MVA, which is a probably indicator for the severity of the mitral stenosis. Now we are trying to find out what is the level of PICP in those patients, those who are suffering from rheumatic heart disease. So if you here can see that we performed immunoassay where we found that the PICP level of plasma patient group is significantly higher than the normal healthy controls. Then also we have taken the same patients, those who underwent valve replacement surgery for 1 month, and then the same patients after 1 year, you can see the PICP level get reduced after valve replacement surgery. So as I said that type 3 collagen is also present, so we are curious to know what is the status of P3NP in rheumatic heart disease patients. So here you can see there is also type 1, the P3NP level increased in the MS and MR as compared to that of control. And also the same when we have taken the valve replacement after surgery for 1 month, it significantly gets reduced, and then after 1 year, it again is significantly reduced. So as these are, we have studied previously the synthesis markers, collagen synthesis. Now we are trying to find out what is the status of the collagen degradation markers. So we have taken the plasma level of MMP level. Here you can see the MMP level. It's increased significantly in the RSD patients as compared to control. And TIMP1 level is also increased. And we have taken the plasma MMP1 and TIMP1 ratio, which is an index of MMP1 activity. Here you can see the MMP1 activity increased in MS and MR as compared to that of control. Interestingly, we have found one data. We have taken in a very small number of patients the urine for both the normal healthy controls and also RSD. And we have found that this PICP level significantly increased in RSD group. Now to perform this diagnostic ability of these markers which we have studied, we have performed ROC, that is receiver operating characteristic curve, to establish a biomarker. We have found that PICP level has been found among all these markers the higher sensitivity. Now we are trying to correlate this PICP with the structural parameter. So as mitral valve area, MVA is one of the severe parameter for mitral stenosis. So here you can see among P3NP and PICP, PICP is showing strong correlations with this MVA. So as the mitral valve area gets reduced, this PICP level has been found to be increased, which is shown an opposite trend with MMP1 and TIMP1 ratio. Here you can see PSP, which is another parameter for the severity marker for MS. Here you can see the plasma PICP showing a strong correlation with PSP other than this P3NP. As the PSP, the systolic dysfunction occurs, the PICP level increased, which again shows opposite trend with plasma MMP1 and TIMP1 ratio. So with this we can conclude that it indicates the collagen synthesis on mitral valve is more favored compared to degradation with disease progression in mitral stenosis. The same thing we have done with the mitral regurgitation. We are correlate with this PICP with the LVI-DD, and we have found a strong correlation with the PICP with the LVI-DD. Same with the LVI-DS, where we can indicate that due to extensive fibrosis on valvular apparatus that occurs progressively with ventricular dilatation, that as dilatation occurs, the plasma PICP increased. To validate our data, we have taken the tissue samples from those MS and MR, and here you can see we did histopathological studies. This is first one is the A is the HE staining, where you can see the infiltration of the inflammatory markers, and the B is showing the massing trichome staining, where you can see that there is an extensive depositions of collagens in the patient RSD samples compared to that of control, whether in the control there is a wavy normal collagen structure. To assessment of this collagen deposition, we have done picroserous red staining, where we have performed polarization through polarization microscopy the depositions of this type 1 collagen. And it's by review literature we found that under birefringence in picroserous red staining, type 1 collagen is showing red and type 3 collagen is showing green. So here you can see as in the RSD patient samples, the more red color is showing the type 1 collagen. And when we have done the total intensity of this collagen, we have found that in RSD it is significantly increased. And we have also found the mean intensity and found in the patient group, in the patient, RSD is in the collagen deposition is increased. Also, we have taken the collagen type 1 and type 3 ratio and found this type 1, type 3 ratios more in these RSD samples. To again validate my study, I did immunohistochemical localizations of this collagen type 1 in confocal microscopy. Here you can see, here I have found that type 1 collagen is located and found increased in RSD samples. To summarize my study and conclude, I got circulatory markers of collagen metabolism remarkably increased in RSD, where PICP increased 377% in MS and 245% in MR compared to control. Concentration of plasma PICP as well as MMP1 TIMP1 ratio, index of MMP1 activity show strongly correlated with echocardiographic parameters for RSD diagnosis. The histopathological alteration of the arising out of fibrosis and the associated disturbance of LV function correlated with remarkable elevation in circulating PICP levels. Therefore, we thought that maybe an antifibrotic agent may be helpful for therapeutic intervention of RSD. We have some study limitation. Due to technical limitation, histological alteration, collagen distribution in other parts of cardiac tissue could not be shown. It would be interesting if some controls with some hemodynamic status, but not related to in order to better appreciate the specificity of our findings. Presence of larger multicentric population would have helped to validate these current findings. I would like to acknowledge our clinicians from India, Dr. Shantanu Datto, SSKM Hospital, Kolkata, Dr. Sudip Ghosh, Dr. Shelly Chatterjee, Dr. Monodeep Bishwas, Dr. Sanjeev Patari, Dr. Naveen Sinanda, and my PhD guide and my mentor, Dr. Arun Bandopadhyay, under whose guidance I performed all these experiments. My lab mates, and part of my work published in International Journal of Cardiology and in PLOS ONE. I would like to thank to CSIR for funding me for this work. And also I'd like to thank to Omics organizer for giving me this opportunity to present my work in front of you. And this is my lab, and this is my PhD guide. Thank you, all of you.
So that was really a very well done, interesting study. So I wanted to ask you, do you know the PIP is elevated in patients just with mitral valve regurgitation or mitral stenosis, which is non-rheumatic?
There are some reports in hypertensive heart disease. In other groups they have did, but it is not, that much work has not been done.
Okay, because that would be interesting to see.
Yeah.
To control regular MR, non-rheumatic MR, and
that is a,
MS. Other questions?
Yes. No, we have compared with the controls, and in the tissue samples also controls, but there we have done the histopathological analysis, there is no fibrosis. Okay. So no, they are not suffering, sir. If you find my earlier slide, I mentioned that they are not suffering from any kinds of disease. PICP? Not get it, sir. So by clinicians, they have, we found that these control samples or the normal healthy individual, they are not suffering from any other bone disorders because of what collagens will be increased or any kinds of. So I don't know that.
I think he's asking in the patients that you've taken with rheumatic valve disease, did you look for any other inflammatory markers or pro-fibrotic markers in these patients?
Okay, no, we are actually looking for this TGF beta markers we are to study, but as the fibrosis occurs, we are done only histopathological studies, and as we have taken the post-operative samples, so when valve the collagen get decreased, the collagen level, but there is this is a part of myocardium, so we are thinking that mainly the valve is involved. So, and it is our limitation that we cannot take the myocardium samples. So, but we just find that in before valve replacement, the collagen level is so high and almost 377% decreased. So maybe it's a point that.
All right, thank you very much.
Thank you.
I think the last person we have is Deepak Kar, who's going to talk about the mechanism of mitochondrial dysfunction in hypertrophic cardiomyopathy.